Hello, everyone. Welcome back for session 2. This is a panel discussion with doctors with physical and mental health disabilities. Our panel will be moderated today by Dr. Michael Argeni, who I will introduce right now, and he's going to introduce the panelists. Michael is a board-certified preventative medicine physician and American Academy of HIV medicine specialist with unique expertise in HIV and sexually transmitted infection, prevention and treatment, including harm reduction. He is currently in a 2-year combined clinical and research addiction medicine fellowship at Wake Forest School of Medicine in Winston-Salem, North Carolina. He previously completed his MD at Creighton University and his MSW and MPH at Boston University. As a physician with hearing loss, Dr. Argeni has authored and co-authored articles advocating for disability inclusion in medicine. His past lawsuit, Argeni versus Creighton, is also a landmark disability case law taught in law schools across the country. In his spare time, he reminisces about New England fall hikes with his dog, Bruins hockey, and the ever-growing list of books he'll never finish reading. Michael, please take it away.
Hello, everyone, and thank you for having me here today. So we're going to be doing a panel today where I get to introduce this wonderful panel of physicians with disabilities who include Justin Bullock, Walker Keenan, Diana Cejas, Hayam Masaban. So as kind of an overview, what I want you to take away from today is to compare and contrast the lived experiences of doctors with disabilities and how that has impacted their journey through medicine. Explain how multiple intersecting identities may inform our panelists' approaches to navigating medicine, and evaluate how their lived experiences can inform your structural assessment of your current or future programs or institution readiness for doctors with disabilities. So in lieu of me explaining where everybody is coming from, I thought I would let the panelists give them their stories a little bit each and let them tell you what they want you to know. So we'll start with Dr. Justin Bullock.
Hi, everyone. Once again, my name is Justin Bullock. I am a second-year resident in internal medicine at UCSF. If you could go to the next slide. And I'm going to talk about my experience, my journey with bipolar disorder. So I have to start. This is me back in Detroit. That's where I'm from, running track. This is my high school. My journey to sort of my diagnosis with bipolar disorder went through many steps. And I first started getting depressed in high school. And so for much of my early life, I sort of went through life with the diagnosis of depression. And actually wasn't until medical school when I was diagnosed with bipolar disorder. My journey, my depressions are sort of the most disabling part of my mental illness. And I've attempted suicide multiple times. Can you go to the next slide, please? And this slide has a picture which I think we often hear a lot of messages about sort of not showing suicide like in a positive light. This actually is in the hospital. This is in residency about a year ago. This is probably a week after I had a suicide attempt where I was sort of medically hospitalized. And these are my co-residents who actually snuck into my room and were hanging out with me. And I included this picture for many reasons. One, because first, it's just a very happy picture for me in a weird way in a very terrible time. But mostly because I think by looking at this picture, no one would ever know that I was actually really struggling. I think that that really actually encompasses my journey with bipolar disorder in the workplace, and that it's something that it doesn't really show in my day-to-day for people who aren't very close to me. I have that picture. And then my last one is, so since then, I faced a decent amount of stigma and bias in trying to get back to work. And even though I haven't had any issues in the workplace, actually had to go through a pretty traumatic fitness for duty process to be evaluated to be determined that I was safe to return to work, even though there was never any concern raised that I was unsafe. So I'm back in the hospital. I love medicine. It's definitely been a journey. I'm excited to talk more about it. And I'm really excited to learn from our other panelists. And I will pass on to Walker.
Thank you, Justin. So I'm Walker. I'm a third-year psychiatry resident at Yale. And I will start with the first slide. You can change to the next slide. So this is a picture of me from a very long time ago. And I thought I would start here because I was diagnosed early on with a nonverbal learning disorder. And basically how this impacted my school performance is taking longer on like tests and things that were of a time nature. And it didn't affect my ability to understand the material was not compromised, but my processing speed to get through the material was slower. And, you know, that was corroborated through neuropsychological testing, where on other types of assessments I did well, and then on the issue of processing speed I did much lower. And so I got accommodations at a very young age, so that in school I got extended time on tests and that sort of thing. I got access to, it's gonna date me, but an Alpha Smart, just like a precursor to a keyboard where you type up things in school so that you wouldn't have to, you know, I wouldn't have to show my bad handwriting. So those were some accommodations I got early on. And I was fortunate to have, you know, parents who were educated who could advocate for me early on. And so when I needed accommodations, I could get them in school. I had accommodations through college. One of the biggest difficulties was getting accommodations on standardized tests, which I'm sure I don't need to tell anyone here about the difficulty of that. I was initially actually denied accommodations despite having 15 years worth of documentation of having a learning disorder, which was very challenging and may have actually prevented me from becoming a doctor. And so that was probably one of the biggest difficulties. But in residency, I've also been able to get accommodations through dictation software and other things. And so I've had this learning disorder for a long time, but I've been fortunate to have accommodations, and it has reinforced my mission to help everyone have access to a medical education and medicine if they want that for their career. Okay, and sorry, next presenter. Oh, so I should have gone through these slides more in order. This is medical school. And then the next slide is residency. Thank you. So Diana Cejas is our next presenter, who is assistant faculty member in neurology at Carolina Institute for Developmental Disabilities at UNC Chapel Hill.
Thank you so much. That's me. My name is Diana. My pronouns are she, her, hers, and I'm happy to be here today. You can go on to the next slide. This is me and my mom when we were on our tractor. So my mom was pretty young when she had me and then had my sister. So we all lived with my grandparents, my maternal grandparents, on my family's small farm in rural North Carolina. And that's where I first fell in love with nature and biology. And that's also where I first got my first taste of how medicine works for working families, or families from rural areas, families who are lower income, families who are Black and Latino like me. We were less than an hour from some major academic institutions, including the one where I work now, and Duke and some other really big medical centers, and still access to care was a really huge issue for us. Going to the doctor was just, too expensive. We couldn't afford it. So any kind of minor illnesses, major illnesses, to be frank, things like the migraines that I and my sister and my mother and countless other people in our family had, you just took care of those things on your own. You just got used to, from a very young age, not being able to rely on the medical system. And unfortunately, that was something that I kind of experienced even later as I went into medical school myself. I went to Howard University College of Medicine. And while I was there during my first year, thank you, you can go ahead to that next slide. During my first year of medical school, I found a mass in the right side of my neck. And it took 5 years of going to various doctors, asking them to look at it, saying that there was something going on, and being told that it was nothing, or that I was exaggerating, or that I just had the typical medical student hypochondriasis. Before I actually got my diagnosis and found out that I had a rare neuroendocrine tumor, which I was told was, never malignant. Only in my case it was. So I went through the cancer pathway, got that workup, had a couple surgeries. Everyone thought I was going to be okay. And then unfortunately, after one of my surgeries, I had a stroke. And this occurred while I was right between my second and third year of residency. So I was getting a crash course of what it meant to be a physician with visible and invisible disabilities, and how the system is just not working for patients with disabilities in medicine. So after several years, a lot of struggling, taking time off to get a master's. I always think it's funny to say I took time off to go to grad school, but taking a little time off and then going back and doing my neurology training, I have learned so much and grown so much, and I'm really committed to still what I had wanted when I was little was to be able to go back and help little kids and families like mine. And now I'm trying to do that for multiple levels, both for my clinical practice, for my advocacy efforts. That's me at a Capitol Hill event where I got to talk with a bunch of legislators back in 2019, and just trying to be a better person and hoping that we can make medicine work better for people and for people like my patients and people like my family and me. Oh, and I'm sorry, let me introduce the next person. I'll turn it over to Payan Masaban.
Thank you. Thanks so much. It's such an honor to be here and with such distinguished panelists. You can go to the next slide, Michael. So I have to include this requisite family picture from Sears or J.C. Penney. I don't know if this was like an immigrant thing or a sort of like a lower socioeconomic thing, but this sort of is the first thing that is very important for me growing up. My family, and of course, so I'm the little one with the wings at the bottom right of the picture there, and so family is one of the things that has been sustaining for me for sure. And if you want to go to the next slide. One of the other things that was very important for me is my path in medicine. And I started out in surgery, and that was asked if we had a picture in the hospital. And so I spent a lot of time in the hospital as a surgery resident, and this is one that was overnight at the Santa Clara Valley Medical Center. So medicine was one of those things that I felt like I was very important for me, and it was something that I felt so strongly about, and being in surgery as well. And it was during my third year in surgery that I discovered that I have a rare progressive myopathy. And it's one of those things where you sort of realize that the kind of denial that you're in. At one point, I remember that even during residency, I think it was in my second year, my foot got caught and I sort of tripped, and I assumed it was the shoes. So I got rid of those. I got rid of those shoes, and it was not until another year where I essentially self-diagnosed with a progressive myopathy. And if you want to go to the next slide. So as a result, I switched to radiology and was very blessed with support and the opportunity to not only become a valued member of the radiology department here, but then to move on to become the program director of the residency. And so that is, with some shortcuts, that's my story. And I just feel so honored to be here and a part of this movement to help support each other and to ally with each other to advance our mutual goals. I want to pass it back to Michael.
Thank you, all of you, for giving us some of your story, because not everybody is willing to be here and share their stories and share what it's been, especially in the culture of medicine. So I just want to thank all of you. We've gone over some questions that I'm just going to kind of go around. So we'll start with Justin. Justin, I wanted to know what your thoughts are on disclosure of mental illness during training.
I think it's very complex, and there's no one correct answer for everyone. It really depends on the individual, the institution. I say things that I think about are, I strongly encourage people to disclose to the necessary people when you have accommodations that you need. So for instance, for me, what that looks like is with my bipolar, like nights, flipping back and forth between nights and days is very destabilizing to me. And basically, in order to not have nights like that during residency, first, I think no one should have nights like that. But within my institution, you have to get formal accommodations. And so there's a sort of formalized process to do that. So I think definitely things that will both keep you well and will also help you do your job better. That's when I definitely push people to disclose to the people who, and then, so for me, I care a lot about political disclosure. I think that me being transparent about my bipolar, I believe it helps other people. When I talk openly about, I'm going to therapy, like every Tuesday at 5 p.m., I think that sort of signals to other people that one, it's possible, and two, like, people are doing it. And so, so I think those are some of the things that I think about. And also definitely recognize that it's very scary and that there are some downsides to disclosing. Like, I believe that if I didn't if I wasn't so transparent about my bipolar with my institution, I maybe would not have faced some of the biases that I did in trying to return to work. And I recognize that is a very real thing. And at least for me, I still think that it is definitely necessary sometimes to disclose.
Diana, we had a similar question, except for you. We also talked about disclosing to colleagues. Would you like to give us your thoughts on disclosure?
Yeah, I completely echo Justin's sentiments. I think it's a very personal thing, and I think that one of the biggest issues around disclosure is this whole concept of control and how much control you have over how much you share about yourself and your story with the people around you. For me, when I first I didn't disclose, that I had migraines or some other things going on in medical school or the first part of my residency at all. Just because I had this mindset, which unfortunately I feel like it's pervasive in medicine, that you just kind of have to be superhuman at all times, and that your illnesses are just something that you deal with on your own time, and you get through them however you get through them. But I couldn't do that when I had to take time off for surgeries and things like that. So at first, I just kind of told people on a need-to-know basis. But as some of y'all in residency or people who have experience with residency programs that are small can probably guess, things don't stay quiet in a small program for very long. So even though I kind of only told a few people, stuff started getting around, and then all of a sudden it was like everybody knew what was going on that I didn't feel comfortable with sharing. And I, even to the point where when I was hospitalized, of course, my friends came to see me. I was happy to see them, but then there would be times when, colleagues who I wouldn't necessarily consider friends would come by at night. Other times when I was trying to rest. Literally one time when someone came to see me when I was still in the ICU and climbed into my bed to sit beside me. So there was a lot of boundary issues that were crossed, and I think that it took me a long time to kind of, one, process that, and then two, recognize like, hey, but like this is not okay, y'all. I should be able to, as the person who is sick, control who can have my story and when. As I've gone through training and finished up and come over, I felt much more comfortable with disclosing, to the point where I'm just kind of like, you know what, this is who I am. And I'm very transparent about what has happened, and transparent about my accessibility issues, and transparent about, you know, when I need to take time off to handle these things. So I think that it's certainly easier for me now, but I think that that is with a lot of time, a lot of getting pissed off, and a lot of, honestly, I feel like I have a lot more flexibility now because I am faculty. And I think that thinking about disclosure, especially when you're a student or trainee, it's a completely different experience than it is when you're in a faculty position.
As a program director, I was hoping you could give us your thoughts on disclosure, both from your own experience and from that perspective as well.
Yeah, so I would second what we've heard so far, and specifically, Justin shared that it's complicated and it's not always very straightforward. So I don't think it's a one size fits all recommendation that we would give, at least that I would give, and I think that there are disability in its own is so diverse. There are invisible disabilities, there are visible disabilities, there are progressive disabilities, right? So I think that for me, I was very open starting and had a reaction that I wouldn't exactly classify as supportive by program leadership early on, even though it was invisible at that point. And I was talking about something that may or may not happen 5 years down the line. And so I'm happy that I was open early on. But if you would have asked me at that moment, I might have said maybe I shouldn't have disclosed in the way that I did. But so the bottom line answer is that I think that it's nuanced, and that I think that you do have to think about the pros and the cons. But I think people should realize that, you know, reasonable accommodation is part of the law, and that there are all HR departments have a process to deal with this. So I don't ever think that if you want to disclose and feel like you should disclose, that you should feel like there's nothing that can be done. But I would weigh the pros and the cons and think about that as you decide to move forward. And as a program director, I think that I try to be open about you know, how reasonable we can be in terms of reasonable accommodation. But I suspect that, you know, just from the practicalities and logistics, people who don't have that experience themselves can find it hard to understand why it would be worth it for them to invest what it takes to accommodate. And I think that that's kind of what we want to bring out into the open about what we bring to the table, what we help make healthcare better, and why it's imperative for us to be recruited, not just tolerated.
Yes, I think as somebody with hearing loss, this is a really common question I get about disclosure, and I agree, it's not one size fits all. Sometimes it changes based on the setting of the training. It depends based on your personal ability, and there's definitely, I have felt like I've had increasing control as I've moved up the ranks, but there's also more visibility of physicians with disabilities in medicine, so I don't know how much that also has been helpful. There's also this feeling or approach of, well, if we make it into medical school or residency, we're exceptional. So Walker, how does the myth that people with disabilities make it exceptional further ableism?
Well, I think that this tactic is one that strengthens the system that is in place, right? And every system is perfectly designed to get the results that it gets, right? And so we're not here by accident, and there is not a purposeful, and that being the key word, barrier ceiling put in place for people with disabilities to get into the medical field. And so when folks are able to get into the medical field, it is often attributed to some exceptional ability that they have, because other people with disabilities cannot possibly achieve that. And I just could not disagree more. I think that people with disabilities are more than able to be in medicine. And I think in many instances, they've strengthened the field, and there's a lot of evidence to back that up. And I think if we continue to say this, we will blame people with disabilities for lack of representation and not the systems themselves. This myth that people with disabilities are exceptional by getting into medicine is needs to be, I think, totally erased. And what we need to do is focus on why are people being left behind? And that needs to be the focus, and less focus on lauding people who sort of have miraculously, made it through, but more so in the systems and how we dismantle those systems to elevate and break down barriers for others.
Yeah, there's definitely a pernicious ableism in that. I so very much agree.
Justin, how do you think we can normalize having a disability to get away from this idea of exceptionalism?
I really like this framework that was made by Dr. Neera Jain, where she basically talks about 3 ways to think about inclusion. First, you can look at the strict compliance like view of inclusion, where you just do what the law tells you to do. There's the spirit of the law, which is like, how do we basically, self-explanatory, think more about the spirit of the law and what the laws are supposed to be about. And then, but finally, this transformative approach, which is how do we explicitly make environments that are not just sort of accommodating to, but actually welcoming and inviting of people with disabilities. And like an easy sort of surface level is like, what if we protect time for people so that every week they have time, like during the workday, to do like whatever they need to do to take care of their health. And that this is something that, like, if you create systems that benefit disabled folks, it actually helps everyone. And the same with me, I mentioned the nights already, like the way that nights are done at many residencies are very chaotic and actually very toxic to your like normal human physiology. And so like, if we create systems that are, more reasonable for everyone benefits. And yeah, just to echo what sort of has already been said, I think there's this, I think another thing that people don't realize is there are so many people with disabilities who just don't disclose. So it's like the person standing next to you has a disability, the other person across the hall has a disability. It's like, you just don't know about all the people who have disabilities. Yeah.
Hi, what do you see as current barriers or constraints on diversity and disability given all of this?
Yeah, I mean, I feel like the systems are not developed to be able to be to be able to have any allowance for deviation from a norm. We talk about coverage of service, and we've sort of set up the services to be covered from this time to that time. So I do feel like there's in general not a lot of flexibility built into the system, and I think that is that's just not good. As Justin said, that's not good for anyone. And so I think that to some extent, one thing that we haven't talked about as sort of disability in medicine broadly is that medicine also as a field is very diverse, and there's surgical subspecialties, there's medical subspecialties, and both of those have various sort of elements of, say, on the physical sort of requirement side. So I feel like it's the systems in general aren't set up to have that flexibility, but also you have individual requirements for certain residencies and ultimate practice that I think make it very difficult, but not impossible. And I feel like it's why the third part, changing the spirit, changing how we approach this broadly, I think will help. But I think we have to be very vocal about this, and it has to be a change much more broadly in the culture. And I think that that's probably ultimately why it is not happening, despite that. I think we all agree, and I think everybody agrees, but the culture changing, I think that's the barrier at the moment.
One of the things you and I talked about prior to setting up this panel is how certain residency programs, because they're stronger, have more adaptability built in for residents with disability. They're more able to get some flexibility on coverage or decrease hours or whatever it is. But then you have this flip side of, well, how do applicants with disabilities get that edge up in order to be competitive for those stronger programs? So there's this tension. So I agree, there has to be a unified approach. Let's see, Diana, how do you think that these programs, what do you think they can do to address these? To get away from the ableism?
I think in thinking about residency programs, thinking about medical education in general, we're really going to have kind of a frame shift on what we think disability is and what we think disability means. I think within medicine, there is this idea that, disability is always inherently wrong. It's just bad. It's something that needs to be fixed. Disabled people are just like treated as if there's some kind of broken thing, and we need to be doing everything we can to fix what is broken. And there's nothing you can do to fix my stroke. I mean, it can be argued that, you could have done something to prevent it, but then there's nothing that you could have done to fix my cancer necessarily. That was a random trick of genetics that just happened to give me the gene mutation that just happened to cause it. You can't really do anything about that on the back end. And I would argue I'm not some broken thing that needs to be fixed. I would say, and if we're thinking about all these questionnaires and things that we look at when we're talking about quality of life, even that is kind of, the way that we ask questions sometimes can be really stigmatizing, because it can be like, oh, well, you can't possibly have a disability and be happy. Like, I think I'm doing okay right now, to be honest with you. And I think that if we start to approach it, especially when we're educating trainees at whatever stage that they're at, that yes, sometimes there are going to be some illnesses that you cannot necessarily fix, but you can still maintain or help the patient have the happiest, healthiest life that they possibly can with whatever kind of accommodations they need, with whatever kind of disabilities they have. I think that just coming at it from that mindset could do a lot to help fix some of the ableism that we're seeing. I think really more focusing on, the fact that disability is such a spectrum, that two people with the same conditions might not present in the same way. They might not have the same needs or the same challenges in accessing the appropriate services that they require. I think if we kind of present disability as not just something that's pathological, but something that is a part of life, I think that could go a long way in helping us as physicians kind of address our own biases, start to help trainees realize that they have their own internalized biases too, and then start to just remember that we're human. We're disabled people, but we are people. And, we should have the respect and access to healthcare that is appropriate and comprehensive that everybody should have. I feel like that's a tall order, but that's what I'm thinking.
I don't think it's impossible. Walker, what do you think we can do to address these barriers in ableism?
Well, I think we have to be very creative, and we have to think about where ableism is and where maybe what we don't think is ableism, but is ableism. And I think we've got to start early on. I think part of the issue is that ableism begins before you were born, right? And every day there's a barrier. And so if you wait until someone is like in college, when they're interested in medicine, to at that point help them, overcome those barriers to get into medical school, it's possible. It's much harder. And at that point, you've lost a lot of people. And so the earlier on you address the barriers, the better off. There was a study done that 41% of people in prisons have disabilities. And the majority of those actually are learning disorders. But all that's to say, looking specifically at the educational system, which is only one system, it's extremely ableist, right? Can you get into the building? Can you hear what the teacher is saying? Are you able to see the child? There's like an infinite permutations of ways that system is ableist. And so if you truly allow equal access to education, which is something that the government is required to do, but they don't live up to that requirement, then I think a significant barrier has been removed. So we need to look at, from the very beginning, where do people with disabilities come into these roadblocks, and how do we help them? How do we create equity within the system, or how do we dismantle the system? And so specifically, I use education as an example. How do we help people with learning disorders, right? How do we help them get equal access to education? That's something that I know well, right? Neuropsychological testing costs like $3,000, right? Which a lot of folks can't afford, not frequently covered by insurance. And so if you are in a family, you can't afford neuropsych testing, you're like not passing your classes or whatever it is, and you fail out of school or whatever's going on, that is not your fault. You've been failed by the government. They have not met their obligation to you. And because of that, you've been robbed of your potential. And so I think we have to start early on and look at the systems that create barriers, from the youngest of ages for people.
Yes, I absolutely agree. And so does our audience. I think there are so many issues at play here. And I also want to fully recognize that we all have intersectional identities. So we're going to move on to what some of the audience has asked. And Walker, I'd like to send this question to you. I'm wondering, and we talked a little bit about this before, but I'm wondering if you can answer this for our audience. How have you thought through the interaction between disability, discrimination, and racism in medicine? And how has that informed how you think about breaking down those barriers?
I think that's a great question. And I think we have to name really the force at play here, which is white supremacy. And white supremacy works by divide and conquer. And the way that works is, we see this happening all the time. Trans folks are banned from getting healthcare in Arkansas. We see this with folks who are, undocumented, unable to get access to healthcare and other services. And so I see this as we all have to look out for each other. And we're not doing an act of charity, right? We're really, it's in our own interest, because when we come together, right, we can't be stopped. And that's how white supremacy works. It divides people up, and so that they feel weak and disempowered, and they don't realize the collective strength. And so I think being at this intersection, I've never known what it's like to just be Black or to just have a disability. My existence has always been both. but what I will say is I think that the biggest thing, the biggest lesson I think I've learned is that we all have to fight for all of our rights, because that's the only way forward. And I think that the way that we do it, in my mind, is to address systems, and to also just name who the villain is. And it's white supremacy. That really is what it is.
I think we have some other thoughts on this. Would anybody like to add?
I think allyship is very important, and I would say that this advocacy in support of each other, I think together we're much stronger, and I think that recognizing the importance of being able to lend a hand, being able to advocate, being a megaphone for our mutual causes. I think that that's very important. Sorry, Justin, you were going to say.
I think that something that I've learned a lot in the last year is how powerful these institutions are. You know, so Walker and I were med school classmates, and we definitely have gotten to work on a lot of cool things together. But one of the things that happened a lot in every institution I've ever been in is that like all the Black people are featured on all the promotional materials, and we're like really marketed as like you're diversity within our institution. And I think this, like, pick any marginalized identity, and sort of like the institutions often, like, there's a lot of fighting that happens, and then something good comes of it, and then the institutions basically promote. They're like, we have this amazing X program, but they don't sort of give credit to the many people who suffered and fought in order for that program to happen. And I think that what you see is people just get burned out of like fighting the fight. And so people leave, you know, these institutions, and then sort of, and so then it's sort of like the people who made the changes aren't necessarily there anymore. And so they sort of kind of cycles back to those sort of toxic power structures. So it's been a very fascinating journey watching how that actually happens, even with an institution that I really love and I think is full of really cool people.
If I may add on to what Justin said, I think it's an important point that I think oftentimes within institutions, I feel like they will allow you just to get enough power to, like, you know, I don't know, like look good on a billboard or whatever it is that they're trying to promote their institution, but not enough to actually affect the structural change that's required. They won't allow you to become a threat to the institution, because ultimately it's benefiting them. And so I think something I've also learned is to be wary of some of these like initiatives that schools have and what they try to do to promote diversity, because I think sometimes it is an attempt to make them look good and to keep the current structures in place that are actually quite harmful.
Yeah, it does take work on our part to not allow these, you know, you don't want the tokenism to replace the real hard work that it takes to move the needle. You know, I would, I mean, I think that, you know, as a program director, I guess in some ways I'm trying to change the system from within. And I do, you know, when these institutions do say, we're going to have this, you know, diversity engagement, or we want to invest in this area, you know, I think the idea is to participate and to try to advocate for it to be more than just a token effort, and keep them honest, keep them sort of keep them doing the hard work that's necessary, and not just some window dressing. But I do think that I would give some credit that I think that they do very much recognize that this is something that's important, and it's incumbent on us to help them to keep it real and not just superficial.
I think just to kind of speak to something that Walker said a moment ago, if we're thinking about institutional change, or even if we're thinking about individual allyship and our own advocacy and activism, we need to be thinking about it from doing the most to really support the most marginalized within the group. So looking at it from like an institutional perspective, if we're talking about, we're trying to improve our policies so that we can make care better for, just disabled patients in general. I mean, we have to look at the fact that, it's not just the disability community is this blanket, one size fits all, everybody has the same needs, everybody has the same things going on. We have to look at the fact, like for myself as an example, I'm not just Black, I'm not just Latina, I'm not just disabled, I'm not just a woman, I'm all of those things together all of the time at once. But my needs as a Black disabled Latina woman who lives in the South are not the same as someone who, honestly, me, had I stayed on the farm and would have been, getting something like $7 or $8 an hour. Those two people might have the exact same kind of backgrounds, but not, again, have the same needs as far as access and things are concerned. If we're thinking about it from a medical education perspective, we're trying to include more, people with disabilities and these broader or more diverse applicants coming to our programs. Again, we need to be thinking about maybe the medical student who identifies in multiply marginalized groups and figure out how we can attract those people into our programs and how we can support them so that it's not just that they come in, we show their face on a brochure, say, yay, look at how diverse we are, but then we're able to retain them and make sure that they are able to get to the appropriate steps and then flourish no matter where it is that they are.
Diana, would you speak to how those intersecting identities conflated your ability to get support for your disability accommodations?
Yes, I think it's hard for me to kind of tease apart what, because sometimes I will have, now people who will ask, with me, as I mentioned, it took, 5 years for me to get the appropriate diagnosis. And then after that, when I first came back to work, getting accommodations for my disability was challenging, to say the least. And some people will say, oh, it was probably because of racism, it was because of sexism, it was because of ableism. I'm like, why not all of them? I can't really tease apart what is coming from where. I mean, there were definitely times when I got a response from certain people within leadership in my program. Some of them were absolutely fantastic and as amazingly supportive as you would ask. And some people was completely surprised. I'm like, I know that you saw me when I was literally intubated in the ICU. I could see you through the window looking at me. I know you know what happened. Why is it that you cannot accept that I need what I say that I need to be able to do the job that I was hired to do? I think a lot of times when people, disabled people are coming in and specifically asking for accommodations to do their job, unfortunately, I think that sometimes the view is that we're asking to get out of doing something, or we're asking to not do the work that we need to be doing. It's like, no, like I came to do this job because I want to be a physician. This is what I want to do. This is what I've always wanted to do. I just need this to support me so that I can physically do the job that I know that I can do. Just because, I mean, my hand doesn't work. What do you want? I can't really change that either, but I can still do the work. I can still be a good doctor. I just need a little bit of some accommodations to support those things. And I think for those of us who belong to these multiply marginalized groups, I think it is easier to fall back on, old stereotypes and bias and think, okay, this person isn't working hard enough. They're not trying hard enough. They're not doing what they should be doing. So I think that it's hard to say, with my negative experiences that I've had around access and negative experiences around, oh gosh, evaluations. I can't say that it was one thing or the other because I'm existing in this body with this last name, with this skin and these disabilities all at once.
One thing that in residency that's been very challenging is everyone is so overworked. And I often feel like if I get any type of accommodations, I'm making more work for someone else. And this is actually very it actually weighs on like us, many people, not just me, I know for a fact a lot, and it really limits people from getting help that they need. And I think that this is one of the big ways that the system, like, it's kind of like, so first, I think this is one of the big reasons why, like, in like surgical, like in programs with like 3 to 4 residents, if one person goes down, like that's 25% of the residents, or, you know, and like I'm in a program with 50 plus residents each year. And so it's like sort of relatively less of the class, you know, if I'm out. And that is a very real challenge that program directors have to weigh. And it's because we are in this system where everyone is working like, you know, 80 hours a week and get like 4 days off a month and like, you know, all these things. So basically, like, without the system shifting, there's kind of there are some sort of limitations that are very challenging to navigate around, both on the program side and on the person side of me. Like, I don't want to make my resident who's already dying, you know, have to work extra days this month or have to do more nights this month or whatever it is.
I mean, the other thing, oh, go ahead, Michael. I was going to say the other thing that we haven't talked about is to what extent the perceptions that are pervasive about medicine prevent people who would be interested in being a physician, just avoid it entirely. And in a sense, what we've done is kick the can down the road because we have sort of projected this need, sort of this superhuman requirement to be able to do this. So there's so many who would be enriching our professions, deciding to not apply to start with. So when we talk about systems issues, I mean, it's very profound, and I think that I do very much appreciate this advocacy and the advocacy of everyone on this panel, because I think that that's the way that we're going to put a lot more pressure on these systems, required pressure, which will help everyone and will enrich everyone, not just as physicians, but our patients as well. And I think that is something that, you know, it's huge when we haven't talked about, but I do think it's something that's important for people to see us and see that please join us. You will enrich us. We want you to be part of our profession.
I wanted to add something, Michael, if I will, just very quickly, which is just to remember about gaslighting and how pervasive that is in medicine. And I think that when we feel that when we are asking for reasonable accommodations that allow us access to employment that we are, you know, obligated to have, and we get pushback and we feel a sense of guilt to others, that is a failure of the institution, and it is the failure of, frankly, an abusive system. And that is really hard to remember, but the residency education system can be very abusive, and it needs to be called that, and gaslighting needs to be called out when it happens.
I have so many questions. I wish we had another hour because there's so many questions about how to assess residency programs, how to disclose, how to deal with retaliation. I mean, and I know from personal experience that there are so many negative things about the system to work through and process. But since we have just a few minutes left, I want to end on maybe a little bit more positive note. How have we dealt with burnout and kept things going? Because when I talked with all of you, you all said it's still been worth it, that you still love medicine, that you still found a place to make it work. How are we doing this? Who would like to start?
I'm enriched. I am blessed with the support of our department and our residents, and it's you know, it's frequently called a thankless job, being a program director. That's not exactly true. You get thanks, but you just have to look for it in these not so obvious places. So for me, the opportunity to be able to instill values in our trainees, that for me is something that is sustaining, and being able to be on the positive side of improving patients' health is something that nourishes me from a spiritual perspective, and that would be my answer for that.
Yeah, I agree. I love my job. I really do. And I'm a pediatric neurologist. I primarily work with patients with neurodevelopmental disabilities. But you know, if you're coming into a neurology clinic, you're probably got some disability of some kind. So I say that I kind of work in the disability space and live in the disability space full time. And it's been just wonderful for me to get to connect with so many young patients. And just kind of watch them grow. I'm a pediatrician by heart, so I just love working with kids in general. But I think one of the things that has been so rewarding for me from the clinical side of things is getting to work with these families and these kids who have maybe heard from multiple other, you know, unfortunately other physicians or other people like, oh, this child is not going to be able to do anything, or they're not going to be able to be productive or whatever. And really just helping them realize, you know, your baby is disabled, but that's fine. That's okay. We can just, I can do is help this child be the happiest, healthiest child that they can be. You know, no matter their disability, no matter their access needs, it doesn't matter. And it's just been really rewarding for me to hear these families talk about how, you know, I mean, yeah, sometimes I feel like I'm not doing very much other than adding on some Keppra and calling it a day. But I feel like getting to work with them and maybe see these kids get to develop and seeing them get to smile and be happy and just be wonderful, it's just so rewarding for me. And then to work with trainees and get to pass on this whole thing about, like, yes, you can be happy, you can be healthy, and you can be disabled too. Hi, I'm here, and I can show you if you don't believe your patients. That's unfortunate. But getting to kind of show my trainees, like, this is what your like patients, I don't want to say like I'm a role model, that sounds weird. But like this, just kind of being an example for like, you can be this person, you can be disabled, you can be a doctor too. Um, I feel like that's another way I'm giving back, so that maybe when they have their own patients, they can see all this potential that their disabled patients have, and they can just continue to encourage them. I feel like I just get to, I don't know, just have such a great job. And I really love that I get to spend so much time with people who are growing and developing, whether it's in their medical careers or, you know, in life in general.
I echo. I love medicine, despite all my many complainings. But I think specifically, I feel like advocacy allows me to turn my bipolar, which many people view as a bad thing, into something that helps other people. And it actually is really cool to like watch these huge institutions change from like one voice, and obviously one voice supported by so many people, but like, you know, or many voices. Yeah.
I really love psychiatry. Most of my work, 30 years, is psychotherapy, and I'm really learning people's stories and getting a sense of how they got to be who they are is just one of the most rewarding things I've ever been fortunate to have the opportunity to do. I think having my own personal therapy is helpful. I have two therapists. I'm in group therapy. I'm in individual therapy, and I'm very vocal about it. ACG and me requires that you are able to go to doctor's appointments. And so I would say when I was on internal medicine, I'm like, I'm going to my therapy appointment, hold my pager. And I was very vocal because people should know about that. It's so very important. And I also would agree, I think, with something Diana said, that like, I think I get so much, I don't know, I guess power from like seeing myself in patients who are like me and their own potential. And so there are a lot of, unfortunately, there are a lot of trans and queer patients who are on inpatient units because of the, you know, or the way our society is. And I get to be an affirming presence for them, get to tell them, you know, I'm queer, you are too, you can be where I am. And there's nothing that can stop you. So that's very affirming. I would also say my peers and advocacy has been a source of, I think, strength for me. And lastly, I'm very vocal about all my, you know, disability, you know, gay, depression, Black, all of that. I talk about all the time. And so if I go away, I'm not going quietly into the night. So that's something that I think also is to my benefit.
Yeah, I think this ability to be able to generously give and identify yourself in the patient that we work with, regardless of whether that's on a systemic level or individual level, is a lot of what has sustained us through dealing with minority stress. Thank you all for being here today and giving us your thoughts and opening up about your disability, but also your other identity for our audience.